Hello and welcome to a brand new episode of Keep It Real with Dr. Pradip Misal, where we explore unique medical branches, and today it is psychiatry. To talk on it, we have an expert from the field, Dr. Rohan Vanagundi. He has done his MBBS from BRIMS, Karnataka, his MD from IPHB, Goa. Sir has also worked as senior resident, consultant, and specialist doctor mental health in UK, and currently he is running his private practice in Goa. So I welcome you on today's show, sir.
Thank you.
Yeah. So can you tell us a bit about yourself, like native place or how was the environment growing up?
My name is Dr. Rohan Vanagundi. I am basically from Karnataka.
Hmm.
My past is a little bit complicated because I kept moving around in my childhood.
Okay.
So I was born in Gulbarga, but my initial until 5th standard I was in Gulbarga district. LKG till 5th standard I was in Raichur district, Shaktinagar.
Okay.
So after 5th standard, I cleared my entrance exams for Sainik School Bijapur. Basically, it's like a military school. I went into that school, and that was in Bijapur district, and I studied there till 12th standard.
Okay.
Until 12th, I was there. Then after that, I got into MBBS in Bidar district in Karnataka. So around 5.5 to 6 years, I spent my time in Bidar. And later on, I got my seat in Institute of Psychiatry and Human Behavior.
Okay.
Under Goa Medical College in Bambolim.
Mm-hmm.
So I came here to pursue my MD in Psychiatry. So yeah, that was my education thing.
Yeah.
Then I completed my senior residency in Institute of Psychiatry and Human Behavior itself, IPHB itself, for 1 year. Later on, wanted to move out of Goa and try out different professions to see which appeals to me. So since I was interested in teaching, I took up assistant professor post in Nijlingappa Medical College, Bagalkot.
Okay.
So I worked there as assistant professor for almost a year. It was very enjoyable teaching postgraduate students, UG, but it didn't appeal to me much. So then again, I moved to Ballari, Karnataka. And there I joined a district mental health program post, wherein basically it's a community psychiatry post, wherein you go to a lot of talukas, villages, and try to provide specialist services in community health centers throughout the district. Basically, psychiatric mental health services, and monitor mental illnesses, the epidemiology part, the data, and compile the data and send it to NIMHANS further for evaluation. Apart from that, I had my own private practice also in Karnataka for a year. But over a period of time, handling both my district mental health program post as well as private practice, it was tough. And in between, we had our beautiful daughter also. So I was not able to spend a lot of time with her. So it made me rethink my ideologies and like how to go about work, because practice was really good. Then I thought maybe it's better to go in search of work-life balance. So that what pushed me to go and attend the interview for joining NHS in North Wales in United Kingdom. So that's how I ended up in UK. But it was a very, very, very short stint in UK.
I think we will talk about that in detail,
Sure.
Because I think we have kept a session to know more about that in detail, because that is one of the factor when people take psychiatry, they have this vision that they want to go abroad and practice. So I think we'll talk about that. What about your home, sir? Like, are you from doctor background or something like that, or this is something? Why MBBS?
It was a very complicated thing that happened. Actually, I was not supposed to join MBBS. I cleared my UPSC exam after my 12th standard, and I got a call letter from Services Selection Board interview for National Defense Academy and Naval Academy.
Okay.
It was in Bhopal. I cleared the interview, but unfortunately, I fractured my hand. And I developed a cubitus valgus deformity in my left hand. So I was medically rejected.
Okay.
So I was very heartbroken.
Yeah.
But since a lot of my mother's side family are doctors and my father's side family are also doctors, but my parents are not doctors.
Okay.
My mother's a homemaker and my father's engineer in Karnataka government. So he retired there. But since I had influence of doctors, so I thought of taking up, because I was interested in Navy. That white, I did not get opportunity to wear that white uniform. Life had a different kind of white uniform. So that's how I chose.
Sometimes life has a different plan for you.
Yeah, true.
Okay. Any fun memory from MBBS times, sir?
Oh, lots of
Lots
them. Lots of them.
Okay, but you had a very good time during MBBS.
Yeah, sure. Yeah, it was definitely a great time. Yeah.
Okay. Psychiatry is not something which we, after MBBS, which we think for PG as a mainstream branch. A lot of taboo associated with it. So what made you go for psychiatry?
See, for me, I believe it was a very simple kind of a decision, because I was always fascinated with the organ brain.
Yeah.
A lot of people used to motivate me in internship that your physics is very good, you have strength, you take up orthopedics, you can just fix it like that.
Yeah.
But I felt it was more of like a manual job kind of a thing.
Yeah.
Like, I like thinking, basically. I am a deep thinker, and I like to listen to people's stories. And of course, brain is very fascinating that way, because I believe that if brain wants to portray someone as a god, it can make someone as a god, or it can make yourself as a god also.
Yeah.
So that ability and the power that brain has, like, it always fascinated me. So that's what pulled me towards the subject of psychiatry.
It's funny how you mentioned about the being strong, and because recently I had a podcast with Dr. Ketan and we talked about that we joked about being bodybuilder and doing orthopedics and all that. Okay. Psychiatry as such is associated with lot of stigma, taboo, and even now we cannot say that it is completely gone. Even in like public and even among fellow doctors, there are a lot of stigma associated with. So did you face that kind of stigma when you chose psychiatry, or from your parents or friend group said, why psychiatry? It's like that mental ka doctor, like that. It is said still now. So I think that is one of the factor also which prevents. So today we are going to talk about psychiatry as a PG branch, aspiring psychiatrist from taking psychiatry. Did you face any kind of stigma like that, or like how to handle it?
I face stigma even today.
Yeah, it's true, sir.
So you have to accept that it will be like a part of your profession. When I was joining psychiatry, mostly because my parents were from an educated background and they had awareness of mental health, they did not oppose the decision. They were actually happy with it. And also that because I was getting to choose a branch which I love, so they supported me. I didn't face any stigma from my family side as such. I started feeling stigma since my postgraduate days. Like there are certain things which your colleagues from other departments tend to overlook upon, and it's subtle, but it's there. Because even in today's practice, when I'm doing private practice, I get a call from a lot of doctors who tell, I've told them that I have referred to a neurophysician. So I'm not readily expressed that I am referring to a psychiatrist. So it's funny that way, because people, because of stigma, may not come to me and they may not be treated appropriately. So yeah, it is still there. And it tends to cause a lot of burnout, because the stigma tends to wear you down over a period of time. You need to have certain strategies or certain philosophies or ideologies to handle it. Because that was one of the reasons I moved to UK. See, the fact is that stigma is everywhere. It was there even in UK too. So yeah, I basically understood that I cannot keep running away from it. Yeah, that's how I face stigma, and I keep facing stigma even now. Because if you meet someone, people will introduce themselves like, oh, this is my cardiologist, he treated my heart, he's my physician. But you see, if they see me, they don't make eye contact, they just pass through.
You can be like, he's
my psychiatrist. Kind of the recognition, public recognition, you might not get it the way you expect it. But you do get it in educated groups and people who are mentally aware. They tend
because I think such common people, they don't understand that there are a lot of mental illnesses. Even the most common, the depression, that is also one of the illness. They associated with like extreme cases of mental illness. That is like the madness, something like that. That is why they have that stigma. And as you said, going to New York and outside, there's more of focus on the mental health and all that compared to India. That also we are going to talk about. But yeah, as you said, like that. Okay, so I think when people in general, they want to get treated for mental illness or depression sort of thing, even they face some stigma from their people around saying, are you having some mental illness? I think because of that also they feel a stigma to go to a psychiatrist doctor.
Yeah. That's what gives me strength sometimes, because most of my patients are suffering from mental illnesses. Despite that, they have a lot of social battles ahead. Despite that, they tend to come to us. They come in search of us. So I think we need to respect that in the patients. But yeah, they do tend to face a lot of stigma. But I feel that these days, most of the times, because of the awareness that is going around, I feel it's less compared to the earlier days when we used to listen to our professors. They used to tell, Rohan, at our times, we used to not get brides. Because they're like, you will get married to the psychiatrist and you will also go crazy. So that was the level of stigma at that time. But I think now, these days, that has changed.
Because, sir, even I'm very fascinated by field of psychiatry. Sometimes people don't understand that even all of your limbs or all of your body is functioning properly and your brain is not in the right place, your mind is not in the right place. It can make you actually very helpless, even like very well social status, any status. But if your mental health is not in place, and in this era, it is becoming more and more difficult to maintain that. So it can actually render a full healthy being, helpless. So I think people need to understand the importance of psychiatry. Like now. According to you, what kind of personality should take psychiatry and who should not take psychiatry?
See, I get a lot of calls. Even yesterday, I was speaking to MBBS undergraduate. I think counseling is ongoing. So there is no such thing like personalities per se. I usually suggest what is that you talk to someone who is in the branch. That's the first thing you need to do. And second thing, what I like to suggest is that the awareness. A person who is aware of themselves, fully aware, like they know their flaws, they are able to recognize what their inner states are, like their states of mind. They're able to recognize the emotions. Someone with very high emotional quotient, wherein they're able to recognize the emotions, reflect on them, and work on them as and when needed. Because that's very important in the field of psychiatry. That is the second most important thing, emotional awareness. So you are aware.
Empathetic nature.
What kind of nature you are. If not, you undergo therapy and try to understand yourself before you take up psychiatry. That also helps. And the next most important thing is communication. Communication, it's like a surgeon's scalpel for us. It's the tool through which we heal people. So if you're very bad at communication, I've seen some of the residents who were bad at communication initially, but they took extra efforts and they worked on it, and they evolved. By the end, they completed their post-graduation. So if you're confident that you're going to work on your communication skills, or you know that your communication skills are great, please go ahead and take up psychiatry.
And which kind of people think that they should not think about psychiatry?
You are kind of a person, like we call surgeons as shoot first, ask later. Meaning impatient.
No patience.
So you cannot sit through listening to someone else's story, and you are someone who wants a kind of like a quick response, because the treatment takes a very long time, usually from 3 to 6 months. So you should have the patience to wait for that response. So it's kind of a little bit draining that way. Your temperament should be like you're a more patient kind of a person. You're a calm and composed kind of a person. Basically, you bring sense of calmness in the room. Of people who are not able to do that, who are workaholic, some people need to have work all the time. They need to keep working. Usually such people end up in surgical branches. So they might not be very happy taking up psychiatry, because psychiatry requires a lot of sitting, like literally for a long periods of time.
Now I want you to walk us through a day in your life as a JR when you joined psychiatric in IPHB. Like the night shift, the workload. So just People need to get that idea, like how hectic it is, like what kind of work is there when you join.
The training types are different in psychiatry as per se, because getting trained in a medical college with 10 beds is kind of a different work-life balance. And getting trained in a tertiary care center like CIP Ranchi or like IPBAS in Delhi or NIMHANS in Bangalore or DIMHANS in Dharwad or IPHB as per se is a little bit more hectic. There is one more in Vizag as well. In tertiary care centers, the thing is that you are cut out from rest of the branches because yours is a separate institute. The interaction with other departments is less. So you are among psychiatrists, you are among psychiatric patients, and we have something called as acute wards and chronic wards. So these are in tertiary institutes.
Okay.
So in chronic wards, we have a lot of forgotten patients. That's what we tend to call them, meaning the patients who have been abandoned by their families, who have been staying in the hospital for a very long time. They tend to be like your orphans when you are looking after them. So they are under your care through and through.
Okay.
So my day as a JR in IPHB was pretty hectic. We used to have OPDs around 110, 120. And these are not the normal patients. These are patients who require your time. You need to give time for diagnosis, for understanding them, and for even the treatment part. So the OPDs tend to be like pretty exhausting. And there is rigorous documentation because of the legal issues. Because my professor used to always say that a psychiatric diagnosis is also a social diagnosis as well as a legal diagnosis. And it's a diagnosis for life. Because there are a lot of legal aspects associated with the diagnosis that can happen. A divorce can happen, or you might lose your land, whatever per se. Documentation is pretty rigorous, and it's word to word, line to line. So you have to write a lot. You have to hear a lot. You need to have a lot of attention. The OPDs are a little bit hectic that way. And before you go to the OPDs, obviously you have rounds. So you have acute wards, you have chronic wards. Basically, acute are the ones who stay for 1 or 3 months. Chronic are the ones who have been staying with us for years together, abandoned from their family and such. So in the acute wards per se, you have a lot of patients who are in acute psychosis, mania, or alcohol withdrawals, or any drug withdrawals per se. So they tend to make up your major chunk. You have to take rounds. Then again, the rounds are in more detail. You have to assess on a day-to-day basis their modes, their mental status examinations, all that. That way, it was pretty hectic. And the number of night duties will be higher in tertiary care center because you have a set of inpatients who are always there with you, whom you need to care for, not only for their mental health, for physical health as well. We used to have internal duties, meaning ward duties, and we used to have casualty duties, wherein psychiatric emergencies used to come. So that used to be the casualty duty and ward duty part. And the same round stuff and OPD. And we used to have group discussions. We used to have PowerPoint presentations. It's interesting. Most of your days are filled with a lot of interesting stories.
I remember because when I was doing my internship, I think you were a resident at that time. So I remember doing one night shift with you. I mean, we don't have night shifts as such, but I remember, and you are one person I always seen very chill. Usually it is, when you do as an intern, you do your internship under a resident. Sometimes they get overwhelmed in clinical side and all that, and it gets pretty tough, hectic. But you are one person I have always seen very chill, and about the work also you are given like do it, no worries. So that is the kind of personality where I think that is exactly the kind of personalities we need in psychiatry.
True.
Okay. So now, sir, in psychiatry, when we enter psychiatry, we see as a new person, we see it in a different perspective. It's a bit scary. If I'm being honest, it's a bit scary when we are entering psychiatry. When you entered psychiatry, did you feel anything like that it was a bit scary? Or how are the patients there? Are they like violent sort of patients? And how did you handle it?
See, there are a lot of violent incidents that happen with you. It's not that patient intends to do it because of their state of mind they are. You need to have that level of depth of understanding regarding that patient so that you are well equipped to deal with them. in that way. So yeah, you tend to have a lot of aggressive patients who might try to hit you, or they get provoked easily because of their delusions or whatever manic state or withdrawal state. But not majority of the times it's like that. Yeah, maybe 1%, like out of 10 cases that you see, 2 might be violent. But you are trained well enough, you have a good handle on your communication skills, you are able to understand what the patient is seeking. There is something called as verbal de-escalation that we try before, we give them chemical sedations or restraints. So we try verbal de-escalation, where we try to talk to them and calm them down along with your psychiatric nursing staff and all. So if that doesn't work out, then we escalate the kind of treatment, like we go on to chemical sedation or chemical restraints, and then move on to physical restraints. So yeah, sometimes there are scary patients, but not majority of the times.
It is manageable when you start working there.
Yeah.
So that is not something you should be scared of when you're taking psychiatry. If you have genuine interest in it.
Yeah.
Okay. And is there any particular case you remember from your residency days? Maybe a unique case? I mean, obviously, like most of the cases are unique only when it comes to psychiatry, but any case that left a mark on you initial days?
Oh, lots of them. Basically, we cannot reveal lot of cases because of our confidentiality clause.
That's true.
But I can tell you a lot of cases from my private practice. So you do tend to find these cases in private practice also. I had a patient who was suffering from obsessive compulsive disorder.
Okay.
So his obsessions and compulsions were something entirely different. He was worried about germ contamination. But the contamination was in such a way that if a dog passes by, he used to go to a nursing home or a clinic or a hospital and tell the doctor that a dog has bitten him.
Okay.
Convince them of that and take a rabies vaccine. It so happened that over 1.5 years, his OCD had worsened so much that he had taken around 35 rabies vaccine.
Damn.
So I was like, oh my God, how to go along in treating him?
Yeah, it's risky to take so many vaccines.
I know, but basically, like, how is he surviving? How is he handling? How to go about it?
Yeah.
And along with that, he had other kind of compulsive kind of a thinking, wherein he used to go to gym, and one of his gym partner, per se, he had expressed that he was involved in having sex with sex workers.
Okay.
One day when he expressed that, he came to me, running to me, asking for a HIV test. I was like, why? He told me like one of his colleagues is involved with sex workers. I was like, does he use protection? Yeah, of course. Then why are you worried? No, because he uses the same gym instruments as I use. So maybe through the sweat, I might get I might get affected with HIV.
Yeah.
So that was the complex level of obsessive compulsion, meaning going towards a delusional level. So yeah, pretty much so many cases as such.
Yeah, that definitely is one of the unique cases.
Yeah.
Okay, we'll discuss more about that later. But yeah, after completion of your MD, what are the career options that are open immediately after you complete psychiatry MD?
See, there are several of them. First one is you can join a medical college as a faculty for experience as senior residents, and then again move at the ladder, the same assistant professor, associate professor. Majority of them tend to go this way. Or else you go out and you tend to start your own private practice. Or you work under another private psychiatrist who already has a de-addiction center or has a well-established psychiatric hospital, and you gain that experience. Or else you join a corporate setup like Apollo, Fortis or whatever, and you go into corporate psychiatry. Or you can even end up doing super specialty branches. There are 5 of them. DM. You can go for addiction medicine. You can go for child psychiatry. You can go for geriatric psychiatry. You can go for forensic psychiatry. This is available in MHANS.
These are DM.
Yeah, DMs. And consultation lies in psychiatry. So you have a scope of going into super specialty branches.
And how much earning potential, like as a freshly passed out MD, how much earning can be there?
See, I will give you an honest take. What I have understood is it depends on the location of where your services are needed. So you go to a typical city like a Bengaluru, Hyderabad or Mumbai, you join a hospital or you join any hospital, I think the starting pay would be somewhere around 85 to 95K. But I feel it's true to most of the field because you have a lot of specialists, tends to be a little bit saturated. But if you prefer to go towards north side, wherein there are a lot of de-addiction centers and they are in need of psychiatrists like Punjab, Rajasthan, Jammu and Kashmir or northeast side, they tend to pay you more.
Okay.
More meaning like even up to like 3.5 to 4 lakhs.
That much.
Yeah. If you have good experience.
Not as a freshly passer.
Not as a freshly passed.
You definitely need experience.
You will definitely need some. What I have observed is that a minimum of 1 year experience post MD to up till 3 years.
Okay.
If you want to go abroad, then maybe some certain countries might expect 5 years.
Okay.
So, but UK, I think it's 3 years.
Okay.
Along with your MRC psych. Even in Middle East, Dubai, Oman, you get a lot of psychiatry offers. I had got an offer from Oman also. They also wanted 3 years experience.
Okay. During your residency, what are the skills you need to develop?
One is communication skill.
Definitely.
Because
like your scalpel, you said.
See, communication is a very complicated process per se. Because your state of mind is different, your patient's state of mind is different. So something you might say in a jovial manner or with good intention also, because of their state of mind might be misread or misunderstood. So communication is always complicated that way. So a good hold on communication skills. And basically there are two types of psychiatrists. One is psychopharmacologist, one is psychodynamic psychiatrist. It depends, like what kind of a psychiatrist you want to be. Of course, both need pharmacology skills, psychopharmacology skills, but psychopharmacologists, psychiatrists tend to rely on molecules to treat the patients. Psychodynamic psychiatrists tend to include certain parts of therapy along with medications, like a 70-30 or 80-20 kind of a thing. So if you are interested into therapies, then you need to spend more time training in psychological concepts, understanding psychodynamic skills, psychoanalysis, hypnosis, all that. But yeah, more emphasis on coming to the right diagnosis. I feel that is a make or break kind of a thing in psychiatry, because we have a lot of diagnostic classifications which is very confusing, and most of the times our patients don't fit into any kind of classifications. So that's where you are the one who will have to make a call. What I always try to say is that there are instruments to measure blood pressure. There are instruments to measure blood sugar, but there are no instruments to measure your state of mind. There are certain scales which we tend to say are objective, but they don't capture the whole picture many of the times. So a psychiatrist's view and observations also are needed along with those scales to complete the whole picture. So in our profession, we ourselves tend to be the instruments.
Yeah, so it's not always the textbook definition.
Yeah, so it's you have to fine tune yourself, you have to understand your flaws, keep discussing the way you are diagnosing with your colleagues, with your seniors, with your professors, and what kind of errors you make, like how you tend to fine tune an instrument. You have to keep fine tuning yourself throughout your residency, so that whenever you diagnose in the right way. And of course, treatment part, our psychopharmacology has great medicines. There is stigma associated with it. So that's why you need communication skills to convince someone to take those medications also, so that they can get better. So psychopharmacology part is very, very interesting, and it's of growing interest these days, because certain medicines that we had classified as antidepressants, antipsychotics, mood stabilizers, the classification has blurred now. We tend to use antipsychotics as mood stabilizers. We can use antipsychotic medications as antidepressants also. Consider the example of olanzapine or risperidone. At doses lesser than 5 milligram for olanzapine, we consider it as a mood stabilizer also. We consider it as an antidepressant also. Dosing is a game. You have to understand the right dosage. So if you understand that, then I feel that you will not have any difficulty in treating patients.
So it's like a skill you need to develop.
Yeah, because certain antidepressants like sertraline work well for anxiety disorders at certain dosages. But for OCD, you need higher dosages.
Okay.
And for depression, again, somewhere moderate dosing, like 75 milligram to 100.
So there is not a proper cutout like it is antidepressant. That means you only give it for depression.
No.
Okay.
No. It's much more complex and it's pretty interesting.
After you finishing your junior residency, you join as a senior resident in IPHB itself. So how was that different from your junior residency? What are the differences in work time and all that?
My senior residency was very interesting because you have a legal responsibility also. There are some forensic assessments that are needed to be done by senior resident. That responsibility is not on junior resident.
Okay.
So you get a lot of prisoner patients, lot of insanity pleas wherein they have committed crime and they are claiming to be insane.
Okay.
So you have to be very careful with them. And you have like this early release from jail. Basically, the judge wants to know their mental state, whether they are harm to a society, or what we call it as recidivism, the ability to repeat the crime, what they had done earlier. So they are a little bit complex assessments. So that is a very interesting area. I personally loved it. And confirming diagnosis and deciding on the treatment part. Of course, junior residents come to you with what their treatment is. But in the end, it's you who is going to decide what kind of treatment the patient gets.
So legal responsibilities here. So I think what you are saying is a lot of something which we have seen in movies and all that.
Yeah, forensic psychiatry. Yeah.
Forensic psychiatry is one of your interests that we'll definitely talk about more in detail later. But more of a legal responsibility as a senior resident compared to junior resident. That's what I'm saying.
Yeah.
Otherwise, it was like enjoying.
Yeah.
Because I see you when you talk about these cases, your face lights up. It's like genuine interest.
Basically, in social circles, you will never run out of things to talk about. And that's one of the plus side, I think.
Yeah. Okay. After completing your senior residency, you went back to Karnataka and joined as assistant professor. So how was that different? How was that journey of yours?
That was a very interesting part because you tend to mold someone who has taken up psychiatry. So it's basically like whatever your principles are and whatever your understanding of psychiatry is, you tend to teach them. So that's like a entirely different experience because whenever a student who joins postgraduate who are interested in subject, they tend to give in themselves for the knowledge part of it. So you can train them because ideally I used to say all my PG residents, everyone is going to get MD Psychiatry at the end of the day.
Okay.
Everyone is going to get the same degree. Someone who is clearing in Bagalkot, Karnataka, someone who is clearing in Goa, someone is clearing in Delhi. So all are going to get MD Psychiatry. So learn certain skill set or read those books which others have not read. Meaning the books outside the prescribed syllabus.
Okay.
So that will make you stand apart. If you're reading the same books everyone is reading, you're getting the same degree. So you go to an interview, how will you stand out?
True.
Either you have a different kind of a research work or you have a knowledge by reading other kind of books which other people are not aware of. Some international standard psychiatry textbooks which are not prescribed in Indian kind of a training. I read a lot of psychodynamic textbooks wherein how they change neural adaptation in brain, like how therapies tend to have impact on circuits. That something was made me stand out.
Okay.
And how a molecule even changes the circuit in that detail and that depth wherein the gene expression changes and the methylation changes in DNA. So that depth of psychiatry will make you stand apart from anyone else.
Okay.
So I feel like newer generation of psychiatrists who have come, or even the earlier generation, the old school psychiatry that we say, wherein they did not have a lot of molecules to treat. Earlier they had only chlorpromazine, the older...
there used to be a lot of toxicity also.
Haloperidol. So you have to learn that skill set also, wherein how to use that molecules when these molecules are not working. Newer ones. So it's pretty complex. So I thoroughly enjoyed doing that with my residents, wherein we used to read latest researchers, we used to analyze what are the flaws in the research and try to spend time with textbooks which are not prescribed in the syllabus. Because anyways, 1 or 2 months before the exam, you are going to rack it up and give the exam. but you should have certain knowledge that makes you stand out from other MD psychiatrists.
Yeah, usually we tend to forget it after the exams.
Yes. Yeah.
Okay.
So this is kind of a long-term kind of a thinking that I like to inculcate in my residents over.
Study in a way of knowledge, not just to
clear the exams. Yeah. Think beyond the degree certificate and the exams, because eventually you will pass maybe in 2 attempts or 3 attempts. But what helps you after that is more important.
And I think, sir, older times it used to be different, that you get a degree, you're set for life. But now I think it is becoming more of a skill-based environment, and you actually get recruited based on your skills and not just degrees. Coming to one of the most important aspect, and you also had stressed upon it, that is something you want to spread awareness about. When the students are taking psychiatry, one of important aspect they have that they want to go abroad and practice, because there is a lot of mental health associated scope there. So you worked in NHS Wales as a specialty doctor. How was your experience? And I want to know it in detail, because I think people have a completely different idea when you go in abroad and work.
It depends on what your ideologies are, what your goals are in life, and what are your professional expectations. Okay. So I had certain set of professional expectations, like I wanted to try out the system, work in a different system and gain the experience, like try to understand like what goes around. One was a curiosity was driving factor, and of course better pay will be higher. Dream to go to another country and experience their culture. So I feel a lot of Indian psychiatrists go to Australia, they go to UK, they go to Middle East. So the pathways are clear based on experience. Opportunities are plenty if someone wants to move abroad. What I faced over there was not a problem in working environment per se, but it was more related to my personal life. Okay. Because see, I have to think for 3. If I am alone, maybe I would have stayed for longer because the amount of responsibilities are less. I have a 1.5-year-old daughter. I have a wife. She's a respiratory medicine specialist. So I had to think for the whole family. So that's where I felt that UK fell short for me, at least. Many times what happens is that your expectations might get overwhelmed. I went there with a lot of pride and I started loving my work over there. I got to know that the first patient for adult ADHD assessment, he came in front of me. He waited to meet me for 1.5 years.
1.5 years?
Yeah. He had got appointment 1.5 year back. So that was the waiting period over there. So he was really glad that he got to meet a specialist. So that was like a very stark difference from over India, wherein you can just walk into a clinic and the waiting period over there is high. But of course, the system is more complex over there, more systematic and more smoother per se. So I didn't have much problem with NHS as such. Of course, there is shortage of staff over there because of reduced funding from the government. All that is ongoing. NHS is crippled. They are working understaffed. Despite being understaffed, I feel that they are doing a very great job. But it was the life outside work which was very dull for me. Okay. I had to rethink for my daughter because when I was over there, I used to get videos or photos of my daughter celebrating small festivals like Raksha Bandhan, Ganesh Chaturthi, going around with relatives. It was all so colorful. I found her so happy. I understood that it might take a toll on her mental health.
The father is not.
Meaning like her growing up over there, being away from the family and taking her away from these festivals and all of that.
Sir, when you were in NHS, your family was there or family was here?
No, they were supposed to come along with me in a short period of time. I was supposed to rent a place and I was supposed to get them over there. But then I started seeing cases and people suffering from mental illness. Then I felt that the social structure over there was not very strong. I myself also didn't like it so much per se because maybe I'm a more jovial and a social kind of a person. People who are more like an introvert and who tend to be themselves, who require that peace, may end up liking that society. So basically, it's what your needs and goals are. They keep changing and you have to keep readjusting your ambitions accordingly. So that happened. And the next factor was cost.
Okay.
This is honestly what I feel.
Cost of living.
Cost of living was sky high.
Okay.
I felt that it was kind of soft exploitation per se, but because over here we tend to convert from pounds to rupees, and they were paying me 69 lakhs per annum, and 40% of it is tax. Near to half is gone. So we will get somewhere around 4.5 to 5.5 lakhs. With a family, it's a lot of struggle. So my colleagues who have been there and are doing that, hats off to them. People close to me are staying over there, and they have taken their family over there, and they're making it work. So it's a lot of struggle. It's not less, because a home rent will only come around like 1.5 lakh minimum. That is apart from your current bills, water bills. So the cost of living was sky high. I felt that we live royally over here. Then over there I will live frugally. So lot of facilities I might not be able to provide to my daughter. It was more of a personal life kind of a thing which I did not like over there. The system as such is great. People who like to be organized, and obviously stress is there over there. It's not that there is no stress. There is stress over there. 5 days work a week is very attractive. But the thing is that you cannot afford mates over there. The last 2 days of the week, however it is available, it goes off in doing personal chores. You have to clean your room, you have to clean your house. So it's not actually weekend off kind of a thing. This is my perspective only. People might argue it in a different way. Maybe.
No, sir, Indian culture is completely different. We are a bit of a more social. We need to, on weekends, we need to talk to our friends. We need to go to places.
Basically, socialization is easier over here compared to there. You need to make an appointment. If you want to go out, you have a car, you need to spend a lot of money. You have to spend it on the parking and obviously food, whatever you spend on, the spending is higher. Compared to
as much structure is there when it comes to work, but when it comes to personal things and all, there is a lot of indirect stuff.
I feel that's where we all differ. So psychiatrists, most of them tend to settle down. Some of them have genuine health issues which tend to get exacerbated in India. So they tend to like those kind of places. Basically, they are physically sensitive. So they tend to like that clean air and that fresh water, all that good food and all that. Traffic is very organized, so they might like it. Maybe I am attached to chaos in our country. I like it.
So grass is not always greener on the other side.
Oh, definitely. Definitely.
So I think this is one of important aspect which people need to understand if they are planning to go abroad.
It's not all green. It's not all green.
Also, another aspect, sir, you mentioned that one patient, he waited for 1.5 years to see a psychiatrist. I think in India, people tend to take medical care granted.
That's there. Whatever is easily available, people tend to take granted. That's a brain's phenomenon. Can't do anything about it.
What is the process to join abroad?
See, it's different for different countries. For UK, basically you have to, it's similar like other branches. You have MRC Psych exam, wherein you have to clear paper 1, paper 2 and CASC exams. At least you must have cleared either of the theory papers, and you must be ready for CASC exam. So these are the people who get selected for interviews with minimum of 1 or 3 years of experience. I did not clear any MRC Psych exam. I was able to go through the interview process and clear it based on experience and how I performed. And I had good recommendation from professors whom I had contacts with earlier. So it was networking partly and my experience and my research work that got me there. I did not clear any MRC Psych exam. Basically, I feel that is also one of the factors wherein like they tend to shell out a lot of money in clearing MRC Psych exam. So they tend to, some of them want to monetize whatever investment that they have done in the exam. So I think that is also one thing which makes them stay for a short period of time.
After your NHS journey, you came back to Goa and you have your private practice. So how does that differ from working in corporate hospitals or hospitals in general?
What I realized after working in many organizations, medical college, government setup, Karnataka government and DMHP and Goa government in IPHB, I think it's good to be your own boss.
Definitely.
Although the monetary benefits tend to appear late and you need to be a little bit patient, but you become your own boss. So I decided that I'm going to be a brand in myself. I'm going to make a brand out of myself so that I can sell my services for providing mental health care. Private practice for me gives me 100% satisfaction because a patient who gets well and comes in front of me is because of my work, whatever I have done. And the credit comes to you fully.
Directly,
The amount of satisfaction that you have in private practice, it's difficult to get it in working for any of the institutions.
Okay.
That's the feedback even I have had with a lot of my other colleagues also. Even if they are working in medical colleges or in a government setup, they want to have that private practice. And because of the stigma, I feel psychiatrists do well in private practice because there is a lot of confidentiality. And patients have a way to seek for mental health without having any judgments. So that way I feel psychiatrists can do well in private practice.
Yeah, they can contact you one-to-one basis.
Yes.
Their rapport builds faster, I think.
Yeah.
What things you need to consider when you're setting up a private practice? Is it difficult?
No, it's not so difficult. Basically, you take up permissions, whatever the state regulations are. You just put a table, a chair.
Yeah, because you don't need a huge setup.
Yeah. One thing is that, especially the psychiatric medications part, it's good to have your own pharmacy if you can.
Okay.
Or you have a pharmacist nearby with whom you communicate whatever your needs are, like what kind of medications you prescribe. Because most of them are Schedule H drugs, meaning scheduled drugs, they are regulated. Not all the medical stores will be enthusiastic enough to keep them. So it's better you have a contact of a pharmacist and coordinate with them about whatever prescriptions that you give.
And I think the medications are sometimes unique to the psychiatrist.
Yeah.
It becomes difficult to find it in a general pharmacy.
Yeah.
Okay. And what do you think? What are some of the myths that are associated with psychiatry that you tend to find?
That way, one of the commonest ones are psychiatrists go crazy themselves.
I would deny it. I also think it some point of time, like, I tend to think like that.
No, the patients tend to rub off on you. Not in a crazy way. Like that's what I was trying to say to you earlier, that you are aware of yourself, you are aware of your patterns, your behaviors, your emotions. Then you tend to fine regulate yourself on your own or with the help of another psychiatrist colleagues.
Yeah.
My philosophy is that every psychiatrist should be under another psychiatrist. Yeah. Because you are being overconfident about how you are going to be all the time, what your emotional states are going to be, or what your behavior is going to be. Sometimes brain always needs supervision. Brain is a deceptive organ. You go and stand in front of a mirror, it always tells you you look good.
Yeah.
But that's not the case most of the times. So you shouldn't tend to give in to that. I have my senior psychiatrist colleagues whom I consult after an intense session and tend to try to find out, who know me well enough, my biases and how I tend to work. As a psychiatrist, you need to have at least one or two colleagues of yours with whom you can discuss, wherein they can point you out. Because a lot of our cases, we tend to have transference and countertransference, wherein the patient starts developing feelings for you. Or you might end up developing feelings for them. So who is going to stop you?
Yeah.
So it's always better to have your brain under someone's supervision, so that wherein you know that subtly there are boundaries being crossed and they are going to stop you. So that has helped me a lot. And I am that way to my junior psychiatrists also.
Okay.
So they tend to call me for certain cases. So that helps you protect yourself from errors or making grave mistakes in your practice.
So you need that check on your constant check.
So that's how you don't turn crazy.
Yeah.
That's not what I mean to say.
Yeah.
Meaning that's how you fine-tune yourself and bring yourself on track.
Yeah.
Or you have your own kind of hobbies, or you have your own kind of personal space. What I go through is that sometimes it becomes so overwhelming if I see like more than 5 patients per day. I need a personal space because I have been with humans throughout the day.
Yeah.
I don't need more humans. I need to be with myself. So I tend to go into those zones. So that helps me.
This empathetic nature when you're treating a patient, that sometimes the feelings develop and all that. That happens.
Yeah, it happens.
Okay.
You know hypnosis, right?
Yeah.
There are many ways you do a hypnosis. Even I do it in my day-to-day practice. What I do is Ericksonian's indirect suggestion. Hypnosis was born in Goa, by the way.
Really?
Yeah. It was Abede Faria, whose statue is in Panjim, in Kandolim as well. Kandolim or Kalangot. The statue is of this. He's performing a hypnosis. It's a very huge statue.
Yeah.
How he came to the idea of hypnosis is a very funny story. He was a Brahmin earlier and a cook, his father. And he used to go along with his father whenever his father was cooking. So he used to cut the vegetables. He got converted during the Portuguese era. The father got converted and he wanted to go into priesthood. He got opportunity to go and get degrees abroad. I'm just brushing. There is a whole biography available in Goan libraries on this topic.
Yeah.
What happens is that he is called by the Portuguese king or queen to give a speech on the pulpit where a lot of people are there. So his father is also in attendance. He goes there and he has a stage fright, which is very common. People who have stage fright whenever they go into public speaking. His father notices that he is frozen and he says in Konkani, "Ye sagle baji kator re baji," means you think of them as vegetables and you think you're cutting them as onions. So suddenly he loses that fright and inhibition, whatever is stopping him, and he starts speaking. So that's what gives him an idea of hypnosis, like how a single thought or a challenge or whatever, a word or a suggestion can have an influence on someone's mind. So we are all very easily influenceable that way. So not only with the patients as such, we tend to get influence on a day-to-day basis with the people surrounding us. They shape our character, they shape our thinking, they shape our emotions. There is something called as mere unconscious effect, which I use as part of hypnosis also. Like suppose I need to make you like the color black. I come wearing black shirt every time and I keep using the word black, black, black again. And I tend to point out things. See, the black phone looks good. Oh, look at that. A black car. It looks so good. So unconsciously, I am trying to indirectly suggest you to choose the color black for whatever. So I keep doing it for 3 months and 6 months. You go to a clothing store and you tend to pick up black t-shirt or black shirt. This is what advertising agencies do with us. On the social media. They keep putting Colgate or some brands. And it, although you notice it, but your brain is noticing it.
So that is how advertising can all work.
Yeah. So that's how they tend to put indirect suggestions in your head on what to buy. So that's why whenever you go, you buy Close Up or Colgate, you don't know why you're buying that. You just know that you want it.
Yeah. I never thought about it like that, but there are like deep things going on here.
Yeah. So that way, even your patients tend to influence you. So you need to keep rechecking yourself. Like I had said earlier, mentioned earlier, like you yourself an instrument. You need to be calibrated. So it's good to be under other psychiatrists. This is one of the most commonest myth that you're going to go crazy. Second part is that stigma. I won't call it as myth per se, but this is what one of the things that blocks them. Stigma by their own relatives, that recognition that they want. Because they are spending same amount of time.
More we can say, sir.
Yeah.
Because if you just give us an idea, like how much time do you spend per patient? Like roughly average.
Average will be 15 to 20 minutes.
It's a lot.
Yeah. It's a lot of time.
Profession.
Yeah. Stigma is going to affect you is a myth. Meaning affect your practice. I feel it's more of a state of mind. If you stay strong enough and true enough and you put your foot down, you will be able to handle stigma. If because of stigma, someone is not taking up psychiatry, I would say don't do it. There are ways to handle it. And you can do it in your own way. One of the very interesting way I learned to handle it is do more awareness programs. Go out, speak out, be vocal. There are a lot of people giving out unnecessary information. You're trained, you're skilled. You know what's what. You go out, you do it. You do it actively. Offer yourself out. Put yourself out. So that way, that was one of a very effective way. Not taking up psychiatry because stigma might affect their career is a myth. don't fall for it.
Why do you think the psychiatric consultations are hidden more than the other consultations medical by patients?
See, there is a social aspect to it, then there is a legal aspect to it, a forensic aspect per se. What happens is that mental illnesses is a ground for divorce. So there are high chances that that can be misutilized and the person might be abandoned. There are certain times when single couples come to me asking for medication, saying that their husband or wife are on treatment, and to just write the prescription and give. I don't do it. It can become a legal document and a ground for divorce.
Okay.
So you have to be mindful about the legal issues behind this. Because there is something called as mental capacity in our new Mental Health Care Act, wherein mental capacity is a person's ability to decide on something. Meaning, I'm simplifying it. Sometimes a major psychiatric diagnosis earlier it used to hinder them as incapable of making decisions. So there have been issues wherein people have taken up other people's property, claiming that that person is mentally ill and that they are not able to make decisions. So there is a kind of exploitation that these people, vulnerable people, are prone to. So that's one of the things. The other is obviously the stigma associated with it, that, oh, if I start the treatment now, I have to take it long time. So I tend to handle stigma by giving one of these explanations, like people have hypertension, people have diabetes. So they don't have any problem taking medications throughout life.
Exactly.
You are suffering from a major mental illness. So what's stopping you? Why do you want to suffer in silence? So this is how one of the ways I challenge in my therapeutic sessions for them to be on medications and take those medications even for longer time if needed. And not all the time you need to take lifelong, but yeah, certain major mental illnesses you need to so that they don't reoccur. But minor mental illnesses, yeah, you can take it for a short time and stop them.
I didn't know that there is so much of legal things associated with psychiatry. I had always thought it is just more of medications and like mental aspect of it. But legal also, now that you're telling that there is so much of information you need to have.
Yeah, that's why forensic psychiatry is a super specialty branch.
Yeah.
So there are a lot of aspects to it. See, you can be called as a expert witness. Okay, there is something called as McNaughton's rule or insanity plea, wherein a person commits a crime and claims that he has gone insane. So there your services will be needed to discuss and provide your inputs, whether he is actually malingering or he is actually suffering from mental illness. I have handled such cases before wherein people with genuine mental illnesses were caught up with law. And through this that they were able to come out. Because not every time it's malingering. Yeah, and more cases of malingering too, wherein they malinger to get out of, it's a jail-free card for them. So
malingering means like falsely saying that they have the
mental illness, and they even tend to put a good act, convincing act. So there your services are needed. So a lot of such aspects are there, because as a psychiatrist you need to know a lot of acts. You need to know Indian penal codes. I think, now it is BNS, Bharatiya Nyaya Samiti. You need to know NDPS Act, drug prevention, because a lot of patients who require care on drug withdrawal services come under your. You need to know the POCSO Act, because they undergo a lot of mental health issues due to child sexual abuse. So you need to be aware of it. You need to know Mental Health Care Act 2017, where suicide was decriminalized. Earlier, I think if someone had tried to die by suicide, so they used to do an FIR. Now that's not needed.
Oh, I didn't know this.
Yeah, suicide has been decriminalized until there is a suspicion. The police feels that there is a need, then only it's needed.
Okay.
You need to know a lot of acts. Basically, you are a half lawyer.
Okay, but you said a very good point. You said that even when it comes to other medications like hypertension, diabetes, that are also lifelong medications. But only when it comes to psychiatric medications, people are like, oh, it's a lifelong.
True, yeah. Stigma associated with medications.
It's lots.
As if I take sleep medications, I need to I'll get addicted to it. I ask them, why you don't get addicted to hypertensive medicines? Why you don't get addicted to cardiac medicines? Why only you're worried about this? If the dosage is same, and you're responding well to it.
Yeah.
You're happy with it. Because sleep is one of the most important factors.
Yes.
I've seen that people with sleep disorders come with borderline hypertension and borderline diabetes. Once their sleeping issue is resolved, after 3 months, when you repeat their blood test, it goes back to normal. So such is the importance of sleep. It may be familial also at times. So you might be suffering because it's a familial issues.
Yeah.
If you don't take treatment for it, you will end up with a lot of physical health issues, lot of mental health issues.
So like you said, some of the old people also, they don't get enough sleep and tend to have diabetes as well as hypertension.
Yeah.
So this is something which is like correlating in my brain now. that sleep disturbance can actually put a lot of effect on others.
Yeah.
Okay. And so the current burden of mental illnesses like depression, OCD and a lot of other aspects, there's a lot of burden in India when it comes to youth and all that. Why do you think that is increasing?
A lot of factors. See, there are social factors, there are genetic factors, familial factors. We call it as a biopsychosocial model, wherein the biology is genetics. The psychosocial part is the kind of childhood that they have had, or any past history of mental health illnesses in the family, or the social aspects of it, whether they are from a poor background, poor financial background, the education part, how much are they educated. So all these factors tend to come into play. It is multifactorial. There is no one pinpoint thing to say that it happens because of trauma. It's a very popular word. So trauma is just one aspect of it, because not all people who undergo traumatic situation tend to end up with mental illnesses. We have something called as trauma intelligence, or we term it as resilience, wherein people tend to learn from it and tend to be prepared for further adverse conditions that tend to appear in their life.
Okay.
So it's just one aspect of it. In current scenarios, I feel lot of environmental issues per se. I feel that the world has become fast paced, and the kind of upbringing that we had, kind of upbringing they are undergoing is completely different.
Okay.
Because the kind of facilities and the kind of exposure they are having is completely different from us. So yeah, I tend to get lot of complaints that the children these days are not very resilient. But I feel that it's not a resilience per se. I feel they're more emotionally aware. They're more aware of their needs. They are aware of actually what they want. Most of them tend to have this sense of awareness. So that's why they tend to seek out help when and where needed. So looking at by that way, they're more smarter than us.
Yeah, so as you said, I think a few years back, this mental health, that concept was not there only, I feel. And maybe our previous generation also, they suffered a lot, but they didn't have this idea of seeking out help. That was something, as we said, the taboo or stigma when going to or taking mental health care. So maybe that is also increasing. That is why we see more and more cases and awareness.
We can call it a shedding of stigma in the society.
Yeah. Okay. So you don't think it is associated with the resilience as such? It's more of a...
See, that's what I'm telling. It is multifactorial. Maybe they don't go out and fall down and play and fall down as much as we do. So there is a subtle role of resilience also which is at play. Maybe the adversities are not like what we had. The adversities are there, but the kind of adversities are different.
Yeah, true.
It's complicated. That's why we have this this Gen Z, Gen X, generational thinking pattern and all that, which differs from one generation to other generation.
But you do think that it is increasing? The cases are lots.
Yeah, the cases are increasing. Yeah, they do. But one of the major factors that I see these days is unemployment, I think so.
Okay.
Unemployment is a very contributing factor. They have a lot of degrees, they are educated, but they don't have jobs.
That is a very good point, sir. When you are educated, when you have the qualification, it becomes more stressful if you don't have a job. Because there's no explanation to it.
Yeah.
And then people around you, like, you already have, what are you doing and all that. That becomes more of certain degree or certain qualification. You can't go for some kind of jobs which are below your aptitude.
Yeah.
So that also becomes tough. What is just normal stress? How do you differentiate from it becoming a disorder? Like, when do you actually seek out help?
There is no life without stress. We have stress in our day-to-day life. Okay. It's all about the coping strategies. Coping is what you basically do to reduce your stress. There is good coping strategies, there are bad coping strategies. Bad coping strategies are obviously smoking, alcoholism, drugs, whatever. Good coping strategies, I would say, are like exercise, yoga, meditation, reading, listening to music, watching movies, whatever. Whichever doesn't affect your physical health negatively, I tend to simplify them as good coping strategies. The ones which tend to affect your physical health and obviously mental health also are not very good coping strategies. If you have certain kind of good coping strategies, you will handle your stress. But stress as per se is a very subjective concept. See, I was weak in maths. Before maths exam, I'll be stressed. Someone who is good at maths obviously will not be stressed. He will be playing cricket outside.
True.
So, a stressful event for me may not be a stressful event for you. It is very subjective. So, subjectivity plays a larger role over here.
Okay.
Because the kind of upbringing I have had, the kind of background I am from, for me, it might not be stressful. Staying in hostel for per se.
Yeah.
You see, like people go into MBBS, it's their hostel for the first time. I was in hostel since 5th standard. So it was not very difficult thing for me to adapt.
Yeah.
4 people might be sitting in a car and you might have a road traffic accident. Not all of them will end up with post-traumatic stress disorder.
So that susceptibility also plays a part.
Yeah, susceptibility, your personality, your genetics, your biologic background, how your upbringing was, all these factors come into play.
So, but when does one categorize a thing that I need help?
See, basically, we call it as socio-occupational dysfunction, meaning it is taking a toll on your everyday social life,
Okay.
your occupational life, your personal life, wherein your hygiene is getting affected. You are not socializing enough. You are staying alone. You are staying aloof. You're not taking care of yourself, or you are unable to take care of yourself. You're not able to eat properly, maintain your hygiene, and you're not able to do your work, regular work. What we term it overall as socio-occupational impairment. So when that starts happening, it starts seeping into your work, your studies. That's when we say that you have to seek help.
Okay, I think you have simplified it very much, sir, because one of the main complaint people sometimes have is I'm not able to perform in my work as I used to.
Yeah.
I mean, that can be one.
Yeah, one of the reasons where you go and meet a psychiatrist and get yourself evaluated as to what is getting your performance down.
Okay. So we have talked a lot about psychotherapy and medication. So what difference is there between the two, and when the psychotherapy is enough and when does medication is needed?
Client. What client chooses. And what I as a therapist or a psychiatrist advise. So we have to have decision making wherein both of our needs are what I am suggesting is also happens and what the client wants also happens.
Okay.
So most of the time therapy is advised for milder forms of depression, milder forms of anxiety disorders, or milder forms of obsessive compulsive disorder or panic attacks. That assessment again psychiatrist will do and take a call, like it's on a milder level. So either we can choose, there are like plenty, the menu is very huge in therapies. One of the most popular one is cognitive behavioral therapy. So not my personal choice. So milder forms which does not need medications, you can get well with therapy. Yeah. Or you have some situational thing that is ongoing in your life wherein you're not able to figure out.
Okay.
So at that point, like you're undergoing a breakup or a divorce, not amounting to socio-occupational impairment, but yeah, you are having distress, but to a milder extent, that gets resolved with therapy. You can go for therapy for that. I have an analogy for therapy, how therapy goes. Therapy is not always like how it is portrayed in the movies. Yeah, certain movies tend to capture them accurately. So therapy is something like you are in a dark room. You want to get across the room. So what therapist does not do is hold your hand and get across. A therapist will switch on the light and guide you which furnitures to avoid on the way.
Okay.
Which furnitures you had hit in the past and injured your toe. He's going to guide you through it. But you are the one who has to do it. Okay, because people feel, oh, then what am I doing if he is only switching off the light? No, that's not it. He's going to be there guiding you throughout on what furnitures to avoid, what are the easiest ways to go around, which furnitures he had hit earlier and injured his toe, and how to avoid them by repeating that same pattern and then get across the room.
So he's helping you standing on your own feet.
Yeah. Teach a man to fish. Don't give him a fish. Because then he has to survive on his own.
Yeah.
There is a very good book I would suggest, like if you're interested in psychotherapy and understand the deeper aspects of it. It's written by a psychotherapist by named Sheldon Kopp. And the book's name is If You Meet Buddha on the Road, Then Kill Him. Okay. That's a very interesting title. Because in that he explains therapy in a different way also. Like one day what happens is that villagers who are growing rice every time, all of a sudden find a watermelon growing in their field. So they get scared of it. Oh my God, the crops are going to die. And it's going to, affect them and poison their food and something, whatever, like all the superstitions surrounding it start floating around. So there are 2 watermelons that they've grown. They're huge. People are scared of touching it, that it might be poison. One day a samurai goes through that village and he says, what, you're scared of it? And he just slashes it off. And people beat him up.
Okay.
And they scare him away from the village. Like, this is crazy guy. Like, what is it? And one day a monk walks through that village. And what he does is that he takes a few village elders along with him. He says, like, let us observe it for a day. We are going to do nothing. We are just going to sit and look at it. So he keeps looking. Oh, so it doesn't move. It stays there only. Okay. Next, let us try touching it. I will do first. Then you do it. I will touch. I will wait for a few hours. If nothing happens to me, you people can touch it. Slowly he says, like, let us pick it up and see. So then slowly he cuts it out. Let's taste it. Then he starts eating it. People start loving it. And that's a process.
Step by step.
Yeah, it's a step by step kind of a thing.
Yeah, I did not get where you're getting it now. It's very interesting. We see a lot of therapists and all that, but what is the essential difference between a psychiatrist who is therapist and other therapists?
Other therapists are basically psychologists. They have a degree in psychology. They cannot prescribe medicines, but they are well versed with most of the therapies. Earlier, what used to happen is that both used to be done by psychiatrists. But the thing is that the load on the psychiatrist will be more, conducting therapy as well as treating the patient. So it is like a multidisciplinary team approach that tend to inspire this, wherein psychiatrist is involved in diagnosing. Because psychiatric diagnosis also takes a very long time. It's not a like one thing like you check your BP and okay, hypertension. You're spending time on that. Then you're spending time on explaining the illness, what kind of illness you have. And then you spend time on deciding the medicines. So they tend to not have time to give therapies, which if done separately, if a psychologist do it, then they tend to benefit a lot.
Yeah, and you're also screening the patient who needs medication.
So a lot of psychiatrists in metropolitan cities have a psychologist working along with them. So that what happens is that whenever therapy is involved, they tend to refer them with therapy. Because medicines can be given once in a month. Therapies require a more regular kind of approach, maybe twice in a week or once in a week. So they tend to come on and go. So the healing is ongoing, uninterrupted.
Okay. One of the fear that patients have is psychiatric medications causing dependence. How true is that? Is that fear rational?
A lot of time I get patients, especially on this older benzodiazepine, alprazolam. And this was mostly an unregulated prescription which was given long back, and they have been taking it unsupervised. Yeah, at that time you tend to get dependent on it.
The older medication.
Older medication, not as per se, unsupervised.
Okay.
You're taking medications in unsupervised. No one is there to supervise you. So if a psychiatrist is there, if you're taking for a long time and your issues have resolved, and you still tend to continue it, psychiatrist will stop you from it. He will tend to taper it off, reduce the medication and cut it off. So supervision is a most important thing to avoid that. What happens many of the case, once the patient gets well, they tend to cut off supervision from the psychiatrist and start self-medication. So that's when dependence is a danger factor.
Medication without supervision is dangerous.
Yes.
And we see a lot of older patients also, sir, for sleep and all, they are on benzodiazepines, lorazepam and all that, and they seem to take it for a long time even when it is not necessary. If I'm not wrong, I think benzodiazepines and all are not supposed to be for chronic phase. They're only for
shorter term. Shorter. We use benzodiazepine always for short terms.
Yeah.
And what happens, elderly people tend to have a lot of falls. They tend to have hip fracture or fractures anywhere as such, or head injuries. So we, especially in elderly age group, benzodiazepines or any kind of psychiatric medications has to be supervised, because there is always a small element of sedation associated with these medications. So the dosing is different. There is a lot of polypharmacy going on. There are a lot of interactions going on. That's why, again, geriatric psychiatry is a super specialty branch also.
It's all coming together.
Yeah.
Forensic psychiatry, we did geriatric psychiatry.
Yeah.
And also, there one more fear that the antidepressant and psychotics, they permanently alter the brain physiology, brain chemistry. Is that true?
Not permanently, and not your brain as a whole. To explain it in physics terms, see, there are certain circuits in your brain which have to function that way for you to function normally. But sometimes they go haywire.
Okay.
And they need to be, brought it under the circuit. So that's where medications come in. And yeah, if the damage was there, of course, the change is going to be permanent. Because you're going to get healed by it, right?
Yeah.
So why not change the perspective of looking at it that you're getting healed by it, rather than it is changing your personality or it is changing the way you think. Maybe the way you think was affecting your day-to-day life. It was affecting your personal life, your professional life, your family life. So now, because of that medication, that way of thinking has changed, and now you're okay with it. So I feel it is more of a people always have this illusion of control, that thing wherein that I am me. So they don't want to lose that autonomy. Actually, that's what they're asking.
True.
Whether I lose the autonomy when I go under medications, whether I will
become a different
person. That illusion of control is always at play in our minds, wherein we tend to, excessively think that everything in our life is in our hands. But it's not majority of the time.
Yeah. Medical field, mental health, I think that is like one of the priority aspect. We tend to need to take care of it. There's a lot of burnout in medical field, young doctors, the residents who are joining PG and all that. This work-life balance, there's no concept of work-life balance in when you're doing residency. So how do you handle that burnout, or do you think there needs to be certain changes when it comes to system also? And do you see cases from medical field? How often do you see cases from?
See, it's very common. A lot of burnout cases. That's how I used to start my UG class when I was an assistant professor. I used to ask them, whenever you fall sick, right? In the definition of sickness, you have cold, flu, or cough, or any body ache. You tend to take leave. When was the last time you took a leave for your mental health?
That's true.
So that's how you tend to prioritize, not your physical health as such. When certain things are taking a toll on you, if you take break from it, the burnout gets resolved.
Okay.
But you should have the ability to recognize that you're feeling mentally overwhelmed, and that break is for your mental health, wherein you take time out and do something that you love. Take rest for your brain. Give rest for your brain. So break from whatever you're doing is one of the most efficient ways of dealing with burnout. And it works majority of the time.
Okay.
So take break for your mental health needs. That's how you prioritize your mental health needs, right?
Yes, sir. But there's one funny saying that the leaves in medical field are not the real actual leaves, because you always have to, provide the backup.
I know. So, but I feel that if we take up postgraduate courses, we are smart enough to come up with enough number of reasons for your mental health.
Yeah.
So yeah, like I feel that you should take breaks frequently from your work. That's how you protect yourself from burnout. Frequent breaks, shorter breaks. Some people like tend to take longer breaks, like once in a year kind of a thing. That's what they do. Or they take smaller breaks multiple times a year, once every 3 months, like that.
Do you face any suicidal tendency sort of cases, sir?
Of course, it's part and parcel of my profession. Lots of the time, I find people with medical professional also approach me, people with non-medical professional approach me. Yeah, it's fairly common.
It must be also giving you a lot of gratitude to handle such cases, and
yeah,
the satisfaction is something different because you are saving a life as such.
Yeah, it's not that I have been successful all the time. There have been times where I have lost my patients to suicide as well. Okay. Very difficult thing. But then again, that illusion of control. You're too much into it, you tend to blame yourself and you tend to end up in guilt. But there are certain things that only a patient can do. And there are limitations to your power. I think that's one of the things doctors tend to give into, that kind of thinking, wherein like everything is under their control. It's like a kind of a God complex kind of a thing. No, lot of factors are not under your control. So you tend to come into agreement with it over a period of time with experience.
That I tried my best.
Yeah, I gave my whole and soul.
And that is where you said that check is important. Someone to keep a check on.
Yes.
Because that kind of guilt can become sometimes overwhelming for a field that is, associated a lot with empathizing nature.
Yeah. It tends to put you in kind of a tunnel kind of a vision and kind of go into like a self-sabotage mode. Yeah. Why I didn't do enough, what could I have done better, what if I'd put this molecule, what I had done this way. If you go in that kind of a cycle, the possibilities are always endless about what you could have done.
Yeah, sometimes the fine line between professional thinking and personal thinking can merge.
Yeah.
When we talk about mental health and sexual health, are they related?
Of course. A lot of time people tend to overlook sexual health, mostly because of stigma, or they are shy, or they are feeling shameful. Or they might feel that the patient might get offended. So they don't end up asking for sexual health. For a person of normal well-being, apart from social, mental, physical, sexual health is also equally important.
True.
Though it's taboo to talk about it, there is stigma associated with it. You are a responsible healthcare worker. It's your responsibility that you take up the domain of sexual health as well in your diagnosis or like how it is getting affected. Because my thesis topic involved sexual dysfunction in alcoholic patients. So I developed that habit long back. Usually in my private practice, I get young male patients with headache, body ache, under 45. They are the people many of the times have a sexual dysfunction. But they tend to come with vague symptoms. This is what I have learned out of experience. So the first thing I asked for directly, sexual health is always should be direct and proactive. And it should be initiated from the physician's side all the time.
So they feel comfortable.
Yeah. And they tend to go back satisfied and happy. It's not that they get offended. They are actually genuinely concerned and they don't know how to ask for it. Maybe because of the lack of sexual education in the curriculum.
That definitely there.
So they don't know how to ask for help, for sexual help. So that's why as a professional working in India, it is our responsibility to proactively ask for it. Because there are a lot of culture-bound syndromes too. You have that syndrome. It's supposedly in villages to curb the sexual activity of youngsters because they are more sexually active. They tend to spread out rumors or superstition that masturbation tends to reduce your blood in the body or you become weak if you masturbate, if you indulge in that activity. It is basically to curb their behavior. Such superstitions are made. So that is what we called as that syndrome. Then we have Koro syndrome, wherein they believe that the number of times the sex they have had or the masturbation they do, that penis size decreases.
Yeah.
So when you have such culture-bound syndromes going around, I feel that you have to proactively ask for sexual health issues.
So what are these sexual dysfunctions? What are some of the common cases you see?
Most commonest ones I find are premature ejaculation.
Oh.
And secondly, followed by erectile dysfunction.
Hmm.
So these take up majority of this. Next to them are culture-bound syndromes, Dutch syndrome and Coro syndrome. So most common complaint is newly married couple, male suffering from premature ejaculations. In females, you get a lot of vaginismus cases, wherein the contraction of vagina is not allowing them to engage in sexual activity. And sexual dysphoria, most probably because of lack of awareness of sexual act per se, because of lack of sexual education again. Basically, there is post-coital dysphoria that happens in female because they are not sufficiently satisfied, meaning they don't reach orgasm per se. The whole act tends to become frustrating for them. This is very common in females. So these are the cases which I commonly find in my practice. And especially if they have erectile dysfunction, we tend to get their cardiac evaluation done.
Okay.
Because the size of penile arteries are smaller than coronary arteries. So erectile dysfunction is a big red flag for a myocardial infarction.
Okay.
So you have to take a cardiac history. You have to get a complete cardiac evaluation done. So most of my erectile dysfunction patients have atherosclerosis, where there is blockage. So if you get a patient with erectile dysfunction, I would compulsorily recommend that they get a cardiac evaluation done.
So what exactly is erectile dysfunction? Is there a particular definition sort of?
It is very subjective first, and failure to form an erection is like the commonest kind of a thing. There are certain patients wherein the erection happens like partially, wherein there is inadequate blood flow to the penis. Sometimes there is a failure for erection. Most of the times it is failure for erection, where is a complete failure for erection.
Okay.
So that falls in the category of erectile dysfunction.
Okay.
Then again, it is treated by multidisciplinary team. So basically, psychiatrists evaluate for sexual dysfunctions. So then I try to identify the cause for the erectile dysfunction. Like what is the basically cause? Basically, if it's atherosclerosis, then you have to go for a medical line of management for them. Or if everything else is fine, then it requires a urologist intervention. So you refer them to a urologist for complete evaluation.
What is the role of a psychiatrist in this sexual health?
See, basically, a sexual act is primarily done by an individual by themselves, or there is always a partner involved. See, if a person is doing themselves, we call it masturbation. But whenever there is a partner involved, it is very important that you take a full history of their relationship status. What kind of a relationship they are in. Whether they are married to each other or whether it is a plain relationship wherein they're like just boyfriend, girlfriend. Okay. So the kind of relationship they have and the kind of bonding that they have, the emotional bonding, the psychological bonding, are they in connect with each other? And are they able to communicate their sexual needs to each other? And whether they are in the same sexual requirements wavelength with each other. So you tend to go into those aspects more. Okay. Despite all that, they're having sexual dysfunction like premature ejaculation, we treat it. We treat it with antidepressants mostly, and it gets resolved within a week or so.
Okay. And this sexual dysfunction cases, erectile dysfunction and all, are you seeing those cases in more of a young generation now, young patients, or is there a trend? Because it usually happens in a bit later age group, I feel.
I have seen more in older age group, mostly because of atherosclerosis. Younger age group, mostly it's related to performance anxiety.
Okay.
Wherein they tend to have a lot of expectations from themselves. And because of that, they tend to have erectile dysfunction. It is one of the very commonest cause in youngsters who come to me with erectile dysfunction. Performance anxiety. Like basically that they have like tremendous expectations, maybe because of the pornography that they are exposed to. So they have like a very different kind of expectation from themselves. So they tend to burden themselves, and that leads to failure to erection.
How this sexual dysfunction differs from male and female? Sometimes what happens, women, when they have sexual dysfunction, it's easier for them to access the care because they have gynecologists and all that. But when it comes to men, they don't know where to go exactly. And I don't think there are as such more of sexologists specially dedicated to that field.
There are certain psychiatrists who have dedicated themselves to treating sexual disorders.
Okay.
They're pretty senior psychiatrists who have done that, and there are fellowships available post psychiatry to do in sexual health as well. There are people who treat sexual dysfunctions only per se. So they are available in metropolitan cities.
Okay.
They run a special sexual health clinic as well. So people can go there too. That's not a issue. Or they can go to a psychiatrist.
Yeah. So even psychiatrists, they can go. They don't need a proper like sexual as such.
Yeah.
If you have this sexual dysfunction, sometimes you tend to go to pharmacy and take Viagra and all that sildenafil, tadalafil by yourself. So how dangerous can that be?
Oh, it's pretty dangerous.
Yeah.
It can cause cerebral insufficiency and land you in stroke. A lot of people tend to abuse Viagra and tend to take prescriptions on their own because it is obviously readily available, but not recommended. Not recommended. You need to get a complete physical health profile evaluation done before you take those medicines, because if you have a cardiac history, you have a history of stroke, you are a hypertensive, then the chances of you having that episode while using Viagra is higher.
They can, I think, have the episode of very dangerous hypertensive episode.
Yes.
Even angina and all.
Yeah, angina.
Not supposed to have it.
Yeah.
But I think that public doesn't know that.
Yeah.
Just go and buy it from so it can be life-threatening.
Yeah, it can be life-threatening, definitely.
And as you were talking about this porn thing also, like porn addiction, is that a real thing, porn addiction?
Of course.
And how does it affect the sexual health of?
Or youngsters tend to suffer after watching porn is like majority of the youth spend time watching porn because everyone is curious about their sexual health. Not a taboo. People of all age group watch porn. It should be one of the part of your sexual history that you take because it is easily available. It is available on phone.
Yeah.
So what kind of pornography they watch, or like how long they watch, like how frequently they watch, all that matters. But then again, pornography, if it is impairing your socio-occupational health, meaning it is you started watching it in your workplace as well.
Yeah.
You're watching when you're supposed to spend time with your family, you're watching it. You're supposed to study, you're watching it. So that tends to go into the addiction part of it.
So there are cases like that.
Yeah, of course.
That
lots.
much also it becomes.
Yeah, lots.
Okay.
I've had patient like who had a very serious case of porn addiction, used to watch 3 to 4 hours per day, which is not quite healthy. That too every day. And associated with that, he had compulsive masturbation as well. So it comes to come somewhere in obsessive compulsive spectrum, as we say, because they have problems related to obsession and compulsion. So it has kind of become a obsession kind of a thing that you watch porn, then again compulsively masturbate. That goes around in circles.
So they are most of the time simultaneous addictions. And masturbation.
Yeah. Most of the time they are together.
And how does it affect the sexual health of that person?
See, it tends to become less pleasurable over a period of time.
Sexual life.
Yeah, and it tends to be a more of a illness kind of a thing wherein you're compulsively doing it just for the sake of doing it. Might cause penile injuries as well, or injuries to other sexual organs as well. So yeah, they tend to take a toll.
It reaches to that level.
Yeah.
They are not worried about the injuries as per.
Yeah.
And what are the treatment modalities that are available, sir? How do you go about treating a case of sexual dysfunction? I mean, obviously it depends on what kind of dysfunction is there, but what is the general line of treatment?
It's a very complicated thing because if it is a more like a psychological thing, you tend to do a couple therapy or a marital therapy to bring both of them together at the same wavelength. And most of the time it will be inability of one partner to express their sexual needs. Either they will be hesitant or they will be scared that they are asking more of their partner and in turn putting more burden of expectations on them. So these are the commonest kind of things that I come across. So basically, they don't speak to each other about what their sexual needs are. Most commonest. You tend to get it out in your therapeutic sessions, make it a free and non-judgmental space, and it comes out and it tends to get resolved at that level. So if it's not that and it is entirely like a physical thing, then you tend to go for medicines. You tend to prescribe medicines for erectile dysfunction. You have medicines for premature ejaculation. There are treatment modalities that way also. Or if needed, you refer them to a urologist or a gynecologist as and how needed.
For evaluation.
Yes.
And in India, sir, we don't see that much of sexual health related research or that mentality and that awareness. Why do you think that is? And should it be more promoted? Should sexual education be a part of the education system?
See, I feel that there has to be a safe space and a healthy discussion around sexual health happening in their growing phase, especially in adolescence. Like, what are the safe sex practices? What are the unsafe sex practices? That's what basically is in sexual health curriculum. And that has to be thoroughly discussed, like to the point of exhaustion, like all the doubts of theirs are clarified. But that's not happening. I feel that's not happening in India because it is a taboo topic and it's a topic of stigma. Maybe because of the cultural background, they're not encouraged to talk on it. So that's what might be stopping them to more awareness around sexual health.
I think that starts with family times.
When
some scene comes, we tend to look here and there.
Yeah.
Starts from there itself.
Yeah.
Okay. This masturbation addiction you said, and you talked about this Dhat syndrome. So you have already talked about a lot of myths regarding that. So give us some of the myths that are associated with that, which are actually myths.
Like I said, masturbation is a safe and healthy practice if done under limits. There is a lot of research these days that says that it improves males' prostate health.
Yeah.
And protects from prostate cancer and benign prostate hypertrophy as such. It is good for your psychological health as well, for your mental health, mental well-being. Some of the common myths are like it's mostly among rural people with rural background and not had enough education that they come with Dhat syndrome or Koro syndrome, wherein they feel that the masturbatory practice tends to reduce blood in them or makes them weak. So they tend to get resolved mostly on assurance and psychotherapy itself. Like it's not like that. It is just a superstition which was there to curb your sexual activity. So it's a kind of a healthy activity you can engage in.
What is the limit when it comes to?
It shouldn't cause any kind of interference in your socio-occupational life.
So that time it becomes pathology.
Yeah, masturbation till 2 to 3 times per week is also considered healthy.
So anything that is altering your
affecting your mental health, your social health, your occupational health, you're not able to handle it, go off at least few days or few weeks or few months without it, it's causing you trouble and it's causing you distress, then I would say that.
And as you said, you're always thinking about that during work also and all that.
Yeah. Same is for even sexual activity as well.
Okay. So
twice or thrice is considered okay, like per week also.
Okay. So sexual activity related addiction is also.
Yes. You have sex addiction also.
Okay.
Same as masturbation addiction. People tend to have sex addiction, which tends to take a toll on their personal life, marital discords.
So anything of excess is not good.
Yeah, anything of excess is not good.
Okay. So you already shared a lot of cases with us. So like unique cases. Do you have some more for? It's like really interesting cases.
They have plenty more as such. I've seen certain cases like forensic cases like getting truly resolved because of your reports. Like we had a patient who had committed a crime and he was at the time suffering bipolar disorder and that person had a manic episode and ended up causing a lot of trouble and even murdering someone.
Okay.
So because he was in that state of mind, his sentence was reduced because of the report. That's like a lot of impact. We have had cases of delusional disorders, the commonest one in rural side is delusional parasitosis.
What is that?
Wherein they feel that the insects are crawling under their skin. So one interesting thing is that you have something called as matchbox sign, wherein you give them matchbox and you tell them next time that happens, you collect it and put it in the matchbox and get it. And next time in follow-up, they come back with an empty matchbox.
Okay.
So it's a delusional thing. It doesn't actually think, but they believe that they've actually caught it.
Okay. You also mentioned forensic psychiatry as your interest. So why forensic psychiatry?
Forensic psychiatry is of interest for me because of the cases, because I am very curious about how the mind works, especially if someone has committed a crime, why they did it, how they did it, and what was the reasoning behind it. That takes a lot of interest. My research was on mental health legislation. That is the Mental Health Care Act. My primary interest is that mental health legislation. See, there is no physical health act. There is a mental health act. Why? Because somewhere it borders on violating the autonomy of a person. There is consent involved. Consent works for someone who can give consent. What if someone is not able to consent?
Sure.
You need to draw a boundary. So that's where mental health legislation comes in. That's where the concept of mental capacity comes in. Mental capacity is not something, if a person has mental illness, doesn't mean that he does not have mental capacity. He might have mental illness and still hold that ability to make decisions, take decisions for himself. So that all regulations comes under the Mental Health Care Act. People are not aware of it because earlier what happens, patients used to be tied down, tied into the homes, beaten and mistreated, ill-treated, or sometimes the proper consent was not recorded. So such issues all gave rise to rights. So there are separate rights chapter which is given in Mental Health Care Act. Right to autonomy, right to free legal aid services for person who is suffering from mental illness, and free mental health services. So all that is given clearly in the Mental Health Care Act. So one thing that should provoke us is why a Mental Health Care Act is needed and not a Physical Health Care Act.
Yeah.
So there is something much more interesting going on in there in our profession.
Yeah, very unique point, sir. For giving consent also you need that mental stage.
Yeah.
And not every mental illness patient is,
incapable of making
mentally unfit to make decisions. I think we have talked a lot about mental health, sexual health and all that. Now, any final words of wisdom for young doctors who are aspiring to take psychiatry, this counseling? Some must have already taken, but some of them have this third round coming up now.
See, I feel in the subject of psychiatry, you can thrive only if you love this subject. Definitely. That's a very, very damning point that is there. Of course, it is true for most subjects, but you can manage in other subjects, but you won't be able to manage in psychiatry. You will end up getting burnt out earlier. And you will feel like changing your profession. I know a lot of people who took up psychiatry and later on go on into administrative roles and again give PG and take up different branch. I've seen people doing that also. Not MD, diploma. Earlier diploma was there, not now. So I've seen such things happening. So my word of advice is like, you can choose and change your partner, but you will never be able to change your department. So you have to choose it wisely because that is going to go through your grave. So my recommendation is that do your research thoroughly. Take all the information. We have something interesting concept called Gestalt therapy, wherein the truth is sum of whole of its parts. Meaning, a better way to give an example is that professor switched off the light and he put an animal in the room and he asked the students to touch the animal and try to identify it. Which animal is it? Everyone touched different parts of that animal. Someone said it's a tiger, it's a hippopotamus, it's a horse, it's a zebra. Then they switched on the room, it was elephant. So it's like that. I believe that you have to take perspectives from multiple people before drawing a decision and a picture. Don't rely on one information as such. You take multiple views, multiple perspectives. People who have cleared, take perspective from one who is in training currently, one who has passed out and working somewhere like in medical college, and one from a person who is doing a private practice. So then you will be able to put on a complete picture, as in like what the kind of subject psychiatry is.
True. So this is a very important advice to seek information from people who are already in the field, so that you can address the elephant in the room.
Yes.
Okay, sir. So now we have talked a lot about everything we can say from psychiatry as a branch for PG, then sexual health, mental health, lot of important aspects we covered that tend to be ignored in India basically. And I think this was a very informational episode for even the young generation or general public, not just doctors who are watching. So I think we are very grateful for this kind of information being spread, awareness being spread here, sir. We are very grateful for your time. I think not everyone is involved in this kind of spreading awareness. Most of the people are busy with their personal life and they don't have time to think about this aspect of that this awareness is needed, and there are a lot of false information is also being spread in this era of social media. So for that, they're very grateful that you took out your time and you came here, drove all the way here. And yes, thank you so much, sir.
Thank you, Pradip. Thank you for the opportunity.